Thank you, Mr. Speaker. I'm pleased to rise today and join the debate on motion M456 on palliative care. Mr. Speaker, you will know that over the past 5 years, a number of parliamentarians from all parties joined together to produce the Parliamentary Committee Palliative Compassionate Care report. I joined as a co-chair, Mr. Speaker, with the member from Guelph and also with the member from Windsor-Tecumseh, who I believe you know very well, Mr. Speaker. So it was a real honor for me to join with that group and many other colleagues from all parties to produce the report on palliative and compassionate care. I want to just read a bit of the introduction of that report, Mr. Speaker, to give Canadians an idea as to how this came about and the actual work that was done. The Parliamentary Committee on Palliative and Compassionate Care is an ad hoc, all-party group of members of Parliament dedicated to improving care for elderly, dying, and vulnerable Canadians. It's unique in the history of the Canadian Parliament as it was formed by the MPs on their personal initiative and funded out of their member office budgets. The committee is an example of what is possible, and members of Parliament work closely across party lines on issues of profound concern to everyone. The spirit of nonpartisan collaboration exhibited by the members of the committee is a great example of what Parliament is at its best. Receiving testimony from hundreds of people at 24 hearings and local roundtables, members of Parliament were profoundly impressed by the dedication and depth of concern expressed by Canadians for issues surrounding the way palliative and compassionate care is practiced in our country. Also, Mr. Speaker, I would like to comment that over the course of this study, I had the opportunity to visit different palliative care places and hospices across the country. And one that sticks out in my mind, Mr. Speaker, is when I visited a hospice in the riding of Sarnia-Lambton. My colleague there hosted us for one of the roundtables, and then we visited the hospice. And I was deeply moved by the compassion and empathy that the medical personnel, especially the doctors, showed for their patients, and then the nurses and other support personnel as well. But these kinds of examples, Mr. Speaker, are multiplied across the country. Our job, our task, is to see that these are replicated in many more communities, especially in our rural communities across Canada, and that's at the heart, I believe, of what this motion and indeed the recommendations of the committee actually are all about. Our government recognizes the growing need of Canadians for compassionate end-of-life care. There is no doubt that care should be there when people really need it, but should also be the best care possible and made available at a reasonable cost to Canadians. Despite the fact that most people say that they would prefer to die in the comfort of their own home, the truth of the matter is that about 60% of Canadians spend their last days in a hospital setting. This is clearly not the preferred place to be for a variety of reasons. Care at the end of life in hospitals can take a toll on the patient, their families, and other caregivers, and is particularly taxing on the healthcare system. Additionally, it has implications on hospital wait times for emergency services and may limit the availability of hospital beds. One of the solutions to address this issue and its unintended consequences is palliative care services. Palliative care focuses on relieving suffering and improving the quality of living and dying. It benefits people of all ages dealing with life-threatening conditions such as AIDS, cancer, and cardiovascular disease. Palliative care treats the physical, psychological, social, spiritual, and practical needs of the person who is dying. It also recognizes the needs of that person's family and other loved ones. While many people associate palliative care with hospices and hospitals, it can be delivered in a variety of settings, including long-term care facilities or even in one's own home. And again, Mr. Speaker, I'd like to just refer to a quote from the report. The palliative care philosophy is person-centered, family-focused, and community-based. The philosophy moves us from disease or condition-specific care to person-centered care. No longer will we refer to the cancer patient in bed 4A, or the heart patient going down to pre-op, or the broken arm in 6B getting a cast. As one doctor said from Kitchener, Ontario, Dr. John Meenan stated the following, quote, "Doctors need to move beyond the model of glorified mechanics
Order. I've been advised that the member for Timmins James Bay is not going to be using his 5 minutes of right of reply. So the member for Kitchener-Conestoga will have his full 10 minutes. and that means he has about 6 more minutes.
I really appreciate your compassionate care, Mr. Speaker.
Yeah, and the member, James Bay.
Science and technique are important, but people are more important, and it's people who get sick. Sickness almost always goes beyond the purely physical and purely mechanical. The mind, the heart, the will, the human need to be put back at the center of the doctor's vocation. I think that captures very well what palliative care is. Palliative care has been in Canada for several decades, and yet it's estimated that about 70% of Canadians do not have access to it. Access is particularly limited in rural and remote areas. Historically, palliative care in Canada has focused on care delivered in hospitals by specialists. Thus far, the main recipients of palliative care have been cancer patients who are battling for their lives against this potentially fatal disease. Today, there is increasing demand to make palliative care services available to all people with life-threatening conditions and to have options as to where Canadians will spend the last days of their lives. A recent survey commissioned by Canadian Palliative Hospice Care Association showed that the topic of end-of-life care is an important one for Canadians. This survey also highlighted that Canadians have a general understanding about palliative care and overwhelmingly support it. But the survey also revealed that people need more information about how to access the care available where they live. Like other healthcare services, delivery of palliative care is mainly the responsibility of provinces and territories. As you heard from my colleague, the Parliamentary Secretary, some time ago, this government is already supporting initiatives aimed at enhancing greater capacity in our healthcare system to provide palliative care. And while there is still work to do to improve end-of-life care, I am happy to be able to illustrate to you that progress has been made. All provinces now offer palliative care services to some extent, and there are some promising practices that I would like to highlight. For example, Fraser Health in British Columbia and Niagara West in Ontario have adopted models that seek to integrate palliative care across all care settings and for all types of diseases. In my own home region of Waterloo, Mr. Speaker, I'm aware of a number of services that are available. Hope Springs Support Center is providing support for those who are newly diagnosed with cancer. Lessard House, a hospice. I've heard many positive stories and having some personal contact in terms of patients who have been served by Lessard House in the Waterloo region, and I'm very grateful for that. Hospice Waterloo region, quality care. Also, Sunnyside Home and the Grand River Regional Cancer Program provide hospice care. These health authorities are also building capacity by partnering family doctors with palliative care specialists. Knowing they can draw on this expertise gives family doctors the support they need to continue to provide high-quality, personalized care to their patients. As a routine part of care, physicians are also encouraged to have discussions with their patients about their end-of-care life preferences before an illness occurs, so they can better understand their patient's wishes. Resources that were once spent in hospitals are now being used to support the delivery of services in the community. This has resulted in an overall improvement in the quality of life care provided to patients, as well as an increase in the number of people accessing end-of-life care services. In Winnipeg, the palliative care program offers around-the-clock coverage for people who wish to spend their last living days at home. In order to enable this process, a palliative care doctor issues a medicine kit for use in the patient's home, equipped with all the medications an individual might require to control their symptoms for a period of 24 hours. If necessary, a palliative care nurse can perform a home visit and use this kit on the patient. If symptom crisis occurs, it can be handled right in the patient's home, rather than rushing them to the emergency department that may either be just around the corner or far away from the patient's home. In Montreal, the palliative care program at the Jewish General Hospital follows 500 patients in their homes. That's 500 people who are not in hospital beds, but they will fast-track admission to the palliative care unit for patients who need it and when they need it. Nova Scotia and Manitoba have expanded access to palliative care drugs in home settings. All other provinces have similar programs. This means that at the end of life, people will not have to enter a hospital to get access to required medications or simply to have the cost of these prescription drugs covered. Mr. Speaker, as well, in our budget 2014, we invested $3 million for a community-based model for palliative care to help the Pallium Foundation in their work. Mr. Speaker, changes like the ones I've just described mark improvements in the options available to Canadians as they plan for end-of-life care. Each province and territory recognizes the value of palliative care and has made significant advances in this area, often tailored to the unique character and composition of their populations. A federal framework, and I would urge that we use framework, for palliative care would respect jurisdictional boundaries, complement these provincial and territorial initiatives, and provide additional information about federal activities and research. I call on all members to support motion M456 in the interest of caring for some of Canada's most vulnerable citizens. Thank you, Mr. Speaker.